So we have now the next speaker is Dr. Ammar AlDabbagh. He's a consultant in internal medicine, gastroenterology, advanced therapeutic endoscopy. He is the director of Center of Excellence of Endoscopy Unit at Dr. Suleiman Faqih Hospital. He's the director of the GI Fellowship. Welcome, Dr. Dabbagh.
Assalamu alaikum. Thanks, Dr. Turki. Thanks, Dr. Ahmad, and for the scientific committee for this kind invitation. So I'll go and brief with old and new topic, which is the palliative management strategy in advanced esophageal adenocarcinoma. And we want to emphasize on the quality of life and optimizing the quality of life of those patients, especially in terminal cases. So my objective, I don't have any disclosure. My objective is to define the palliative goals in advanced esophageal adenocarcinoma and to review the options for dysphagia relief to have the decision framework based on survival, anatomy, and goals. And the goal of palliation of those symptoms in their very short time of their life to control the dysphagia, the pain, and the bleeding, if there is any bleeding, to maintain their oral intake and nutrition, to minimize the complications by choosing the appropriate procedure, to align with the patient and family goals and the end of life care. So we used to have multiple options: Savary dilatation, argon plasma coagulation, YAG laser, photodynamic therapy, big tube, nasojejunal, nasogastric, then the esophageal stent and brachytherapy. I might, we will not go much with, or not do much of those that I scroll down. Nowadays, we don't use argon plasma coagulation that frequent for these cases. Even if they have bleeding, we have another way to control it. Big tube angiogenostom, big G tube might be the latest option, and I will concentrate mainly on the esophageal stent and the brachytherapy. The dilatation of the malignant esophageal structure might carry a bit some risk, especially if the mass is ulcerated, especially with the alliance after radiotherapy, after failure of radiotherapy, radiation esophagitis. So we need to be cautious while dilating such structure. So esophageal stent and different kind of the stent. We have the fully covered and partially covered, uncovered stents. And in such cases, we tend to use partially covered or uncovered esophageal stent as it mainly aim for palliation. The only thing about these stents is the possibility of tumoral growth inside it, and here we need to be aligned with the life expectancy of those patients and to consider another modality if we have a tumoral growth, including stent into stent approach or other approach. So the esophageal stent is not only for nutrition supplement, is not only for maintain the oral intake for those patients. You can consider it for structural patency maintenance, either post-radiation, post-palliative therapy, or ablative therapy for high-grade dysplasia if it's resistant, or sometime if the patient at initial presentation was operative, candidate for operation, and he went for surgery, then you might consider it for anastomotic stricture or anastomotic leak even. It has a rule. If there is a fistula due to the tumor, tracheoesophageal fistula, especially if lower esophageal fistula, or if the fistula performed or happened due to radiation or tumoral growth. And if we're gonna consider about the dysphagia as a main concern in our palliative management, so we have these 3 or 4 approach. We can talk about self-expandable metallic stent, which gonna provide us with very rapid relief. However, we have risk of migration, risk of bleeding, and risk of tumoral growth inside it. External beam radiotherapy, it have slower onset, but it can control the bleeding even, and it have more durable, as well as the brachytherapy, it have more durable relief less complication comparing to the stent. However, it needs time to appear. We can consider also combined approach like expandable stent and radiotherapy, which has fast and durable if we have selected cases for this. What's the evidence behind choosing wherever we're going to choose of these modalities? So the randomized control trial, as I'm going to come in the next slide, showed that self-expandable metallic stent in those patients have faster relief, and the brachytherapy have longer control and fewer stent-related complication like, bleeding and migration. And it showed also that the brachytherapy is highly effective for durable palliation, and the combination can be used, especially if radiotherapy and stent can be used in very selected patient they have more than 3 months life expectancy, and they need at the same time rapid relief of their symptoms. This is one of the meta-analysis, which was landmark trial published on Lancet a few years ago, that compared single-dose brachytherapy versus metallic stent placement for the palliation of dysphagia from esophageal cancer. It was multi-center randomized controlled trial, and you can see in these baseline characteristic that they have good number of equal number, between two groups. Sorry. Between squamous cell carcinoma and adenocarcinoma. And they have some good number also of esophageal gastric junction patient where it's somehow difficult with increase the risk of migration in those patients. And most or all of these patients was palliative and metastasized. So you can see that we have more minor complication in the stent in the left side in the stent placement group comparing to the brachytherapy, and we have some kind of tumor resistant and tumor regrowth in the group of the brachytherapy, and the hemorrhage and the stent migration, of course, favoring the stent placement group. You can see also the dysphagia, the overall survival dysphagia adjusted after treatment is going more with the stent, not the upper arrows, not with the brachytherapy group. However, the quality of life, if we're going to consider the functionality, the emotional, the cognitive function, and also if we're going to see the global health status and the self-rated health, always was better with the brachytherapy group. The dysphagia is the only thing that improved more or fast with the stent. And the conclusion of this landmark trial was that dysphagia improved more rapidly after stent placement comparing with the brachytherapy, but long-term relief of dysphagia was better with brachytherapy, and we have more complication with the stent insertion. So they conclude that the single-dose brachytherapy gives better long-term relief than the stent. This is one of the studies. The other studies, which is systemic review, and it compared palliative radiotherapy combined with the stent insertion to relieve the dysphagia in advanced esophageal cancer. It's a systemic review and meta-analysis, and it published like maybe 3 years ago, and it improved. They have 9 very well stated study, retrospective and prospective study, and we can see here that all the group they filled with the favoring the stent insertion, combined stent insertion and brachytherapy group. The dysphagia result as well. However, the other thing, like the result of the bleeding and the migration and the pain, was not a significant difference between two groups. And they conclude that the meta-analysis demonstrates that the patient with advanced esophageal cancer might benefit further from radiation and esophageal cancer stent insertion in median or survival score comparing to do only one of these approach. There were no significant change in improving bleeding, stent migration, or pain. By this, they recommend to have hybrid approach, radiation therapy, and stent placement in those group. This is another Cochrane review for intervention in for dysphagia and esophageal cancer, and they conclude that the self-expandable stent is safe, effective, and quicker in palliation for those symptoms for dysphagia in those patients. However, combined with brachytherapy and radiotherapy might give us a more durable effect comparing to the stent alone. So what's the practical algorithm after these multiple studies and meta-analysis? The practical algorithm is mainly to have a multidisciplinary meeting to decide with your oncology team and radiotherapy team about the expected survival of those patients. If we are talking about very short survival, less than 3 months, then with all the complication of the radiotherapy and brachytherapy, then we might consider stent alone for rapid relief for this short period of time. If you are thinking that we have a survival more than 3 to 6 months or more, then you consider hybrid approach either by brachytherapy with a stent or by radiotherapy with a stent for both rapid and durable relief. Systemic review, I will leave it for, systemic palliative therapy, I will leave it for our colleague oncologist, but we have a rapid change in the management and immuno and chemotherapy of those patients. The nutritional symptom management, you need to always, as you can, consider oral feeding of those patients for the suppression of the hunger feeling and for better quality of life and for better improvement of depression and anxiety. Big tube or surgical or interventional radiological insertion of big tube if possible, but it carries a big burden on their social impact for those patients. You need always to control the pain, opioid palliative team involvement, consider closing of the fistula by stent or radiotherapy, and always involve the psychological support for those patients. So my take-home message to match the intervention to survival and goals, and always have multidisciplinary team with you, radiotherapist and oncologist team. Rapid relief by esophageal stent, but a bit more complication. Combined therapy or hybrid therapy is a very good option for those patients with more than 3 month survival. And by this, I would conclude. Thank you again.
Thank you very much, Dr. Ammar. Just have Dr. Ammar, just maybe a couple of questions for the audience. Please.
Thank you, Ammar, for a nice presentation. Regarding placement of the stents, we have to be careful in two positions, which we have to be careful. Number one, in the lower esophageal area where the stent has to bypass the lower esophageal sphincter, I think we should use stents that has anti-reflux capability. Otherwise, the severe reflux is very, very even worse than the dysphagia for the patients. The other, very difficult location to place the stent if the tumor is high up and the stent may reach the cricopharyngeus. This is sometimes the patient may not tolerate this, so we have to keep. So the best for the regular stent, which you talked about, is if it is in the mid esophagus, away from the lower esophageal sphincter and away from upper esophageal sphincter. That's number one. The other issue is the radiation therapy works very well for squamous cell carcinoma, but it doesn't work for adenocarcinoma. In that case, for adenocarcinoma, maybe just the stenting with anti-reflux or brachytherapy.
Thank you, Doctor. Yeah, the reflux is a very, very big issue comparing the after insertion of the esophageal stent, and the anti-reflux stent is the way to go, as you mentioned. We usually avoid, as you mentioned, the stent in the upper esophagus due to risk of migration up, and we need to find another way. Sometimes the radiologists, especially with bleeding mass, they might do the palliative radiation, even in the case of adenocarcinoma, not for the sake of that those cancer is not a radiotherapy responsive cancer, but just to control the complications such as bleeding or severe obstruction.
Last question, Dr. Hamad.
Ammar, excellent talk.
Thank you.
I was wondering, you put uncovered stent for the sake of you are afraid from migration, right? So, or why you don't put a partially covered and you put clips up? What is your way to reduce stent migration? What do you do?
Good. So first thing, we try not to put a fully covered stent. Not to put fully covered stent. Remember, those patients is palliative patient, and those patients, they tend to have very short life expectancy. So I mean, it's different school, but the best option in those patients that not a surgical candidate is to put partially covered or uncovered stent, because the risk, as you mentioned, the risk of migration with the fully covered stent. The only way that we put the fully covered stent in those patients where we think that we might remove this stent soon, for example, not palliative patient, they are possibly gonna be new adjuvant candidate, then they're gonna go to the surgery, but they just need fast relief of the dysphagia. I mean, putting the clips, or usually the mass itself gonna hang the stent very well because of very tightness of the mass. Putting the clips, the usual endoscopic clips, can be done, but it does not, maybe the other audience gonna correct me if I'm mistaken, it does not show much holding the stent, much powerful to holding the stent. Maybe the endoscopic suture will be the better option for those patients rather than putting a normal endoscopic clip.
Last question, Dr. Wallace.
Yeah, just a comment. So actually just this week, there was a randomized trial published of suturing stents in place to reduce migration, and it was effective. So I think more aggressive measures such as suturing or the dedicated stent fix devices, the more aggressive over-the-scope clip, seem to reduce migration significantly.
Okay, thank you very much, Dr. Ammar. Thank you.